Hi, I'm Colleen Hutchinson. I'm here with Guy Voeller, and we are at the 19th Annual Minimally Invasive Surgery Symposium at the Wynn Encore Las Vegas. Thanks for being here, Guy. Can you just tell us a little bit about yourself?
I'm a professor of surgery at the University of Tennessee in Memphis. I've been there over 30 years. I focus on minimally invasive surgery. I happened to early on focus on hernias, so Dr. Showers had me come here and moderate the hernia session and arrange the hernia session for several years, and so I'm back again.
Well, thanks for being here. Let's just dive right in and talk about permanent mesh and hernia repair.
Big topic.
Yeah. I mean, we've actually gone over this topic for the past few years and on the spots and in these interviews, but
yeah, I think the phrase "a hot mess" is kind of perfectly describes the situation. As the viewers know, the use of permanent synthetic mesh is still the standard of care when it comes to inguinal hernias and incisional hernias. However, there's been a lot of attention recently due to some of the uses of mesh. It was used for pelvic floor reconstruction in the women that have pelvic floor problems. There were some complications from that use. It led to significant legal action. The plaintiff's attorneys won a good bit of money from that situation, so they felt that we won money for pelvic floor, let's just sue about mesh in general. So right now, all of the companies out there that manufacture mesh are facing a huge litigation situation with thousands of patients, and it's going to take years for this to work through the system. Every surgeon has to deal with it every time they see a patient in the office. It's certainly in transition. How it's all going to end, I don't know, but it's a very complex situation.
yeah, I feel like every time I turn on the television, I see another ad for mesh litigation. And so I would think that as a consumer who is looking at like potential hernia surgery, that's the first question that they're going to ask their surgeon. And so when you get those questions, what do you tell them?
Well, that's exactly what happens. You sit in an office and you're going to see 20 or 30 patients, and you're going to have 20 or 30 people ask you that exact thing. And it's a legitimate thing. Mesh is a very good product. It does have some complications, and it's the patient's right to know those complications. But it's so complicated, it's so complex. Asking a layperson to understand all of those complexities, it's too daunting. So you try to help the patient understand as much as you can, but you see more and more patients now coming in saying, fix my hernia, just don't use mesh. And so that adds a whole nother layer of complexity.
What do you do when they come in and say that?
Well, depending upon the situation, you try to advise them it may not be best to avoid mesh in this situation, or certainly I can use mesh. You may have a higher chance of recurrence. If you're not comfortable repairing without mesh, you may want to refer to another surgeon that is more comfortable not using mesh.
Are the mesh companies helping educate surgeons in how to answer those questions at all?
I don't know that that's a prominent thing right now, and I think I don't pretend to know what the companies think, but the litigation mess that's going on right now, I don't know that I would want to sell mesh because of the potential legal issues. I'm not speaking for the companies. I don't know what they're thinking, but it's a big deal.
Switching gears, let's talk a little bit about the robot. We've talked about the robot in different interviews and my column on the spot in General Surgery News for probably the past 4 or 5 years as it relates to hernia surgery, and it's really evolved every year. So how would you characterize the role of the robot today in hernia surgery?
Yeah, it's interesting. We have talked about it each year, and you're going to keep talking about it because the robot that's on the market has had sole ownership of that market, and now more robots are going to come to market, and they're going to be approved, and so it's going to continue to be a prominent part of hernia repair. The role where we stand now, I think certainly as opposed to 3 or 4 years ago when we talked. The number of hernias that are repaired utilizing the robot have increased significantly. We don't know yet whether that is a good thing or a bad thing. There are pros and cons, and at the meeting, Dr. Shower's meeting, we're going to talk about those pros and cons. And so we're still trying to find exactly the true benefit of the robot. And again, I think it's important for the consumer to understand. They come in thinking that the robot is actually performing the surgery, when in fact it's just another means to move the instruments around instead of using an assistant. But it presents a lot of issues, and just like the use of synthetic mesh, it's going to be a topic every year when we come.
Well, and you touched on something that's further complicating things, and that is these new platforms coming to market. So for instance, you have the Da Vinci, you have people who know the Da Vinci and have been working on the Da Vinci platform for years, and then you have a new robot system, the Senhance, which is very different, and others. So how do you foresee education and training on different platforms?
Yeah, it's a great question, and it's it's going to be very, very difficult because each of these platforms are going to be different. And so not only is it going to be difficult for the practicing surgeon to learn all these different platforms, that's not going to be possible. Hospitals are going to have to select which platform they want. Then you have the issue of training residents. There's no way you're going to be able to train them on 3 or 4 or 5 different robotic platforms. So as all of this blows up and these products come to market, hospitals are going to have to make choices, practicing surgeons will have to make choices, trainees will. So you're going to be talking about that on a continuing basis.
Mm-hmm. Well, and you mentioned training residents, which leads us to another question about educating residents and fellows today in hernia surgery with regard to the robot and its role, and laparoscopic and open surgery, which they are having less cases to work on. So how do you handle that?
Yeah, I think that it's important that residents be exposed to all of those different things. In some programs, that can be done. You have good robotic surgeons, you have good laparoscopic surgeons, you have good open surgeons, but most programs don't have that. And so the training is deficient in one way or another in most training programs, and that's why as these complexities arise in training, you see more and more residents when they finish. They go into fellowships and try to fine-tune their skills, because it's asking too much of the system and asking too much of the trainees to try to. It's a difficult task.
Would you say simulation is filling that gap?
Simulation is very important. It's a very good way for trainees to get skills, but it's still not like the real thing.
Yeah.
So it jumps into the gap, but I don't know that it fills it.
Okay. What would you say to some surgeons who are saying, even in presentations at meetings, that laparoscopy is going to be outdated in the hernia surgery field in 10 to 20 years?
I don't know. I would say that could be the case if you're speaking specifically about the laparoscope. I think if our system can monetarily hand what all the inventors out there are inventing, that could be true. I mean, there's a recent robotic system that one of the companies just bought for $3.2 billion. And it's a robot that is used for a lung situation, and one of the larger companies just purchased it, and I'm sure they're going to try to adapt it. So there's so many technologies out there. Virtual reality is going to be playing a role in surgery, so it's potentially that could be the case, that the old laparoscope may be put in the suitcase and forgotten. Who knows?
So Mike Rosen's talk tonight on ventral hernia repair. Are things becoming too complicated? Are we making things too complicated? What do you think? Yeah,
I think it'll be interesting. I can't wait to hear Mike's talk. Mike always creates a little controversy, but I think it's a very good point in that the things that we do, especially with the robot and some of the other, we're cutting muscles and releasing muscles and sliding things around and doing a lot of complex things. While they can help, they can also hurt. And I think we certainly have to pull in the reins a little bit. The robot has added to this complexity thing, and so I think the title of Mike's talk is well chosen, because sometimes the simpler the better, and we tend to forget that with all the fancy new technology sometimes.
Well, in some of these fancy new technologies, general surgeons across the United States and internationally are seeing on Facebook groups, on social media, different cases. And that leads into my next question about the international hernia collaboration online. I know that it's experienced major growth. You had said to me 99 countries, 7,000 members. So let's talk a little bit about that, and also about these new technologies and new cases and sort of renegade surgeons on there, putting on there in video and other descriptive ways what they're doing, and then the impact of that on viewership.
Yeah, it's a whole new thing, and I think, as you mentioned, it's exploded. Facebook, in fact, voted the IHC one of their top health sites on Facebook.
Wow.
And Dr. Jacobs only started it a short time ago, and others have kind of stolen some of his thunder and done the same thing on Facebook. But it's a whole different paradigm, and it's kind of moved away from the ivory tower. And if people want to, like the IHC Premium, which is a separate part of the IHC, you can get really personalized attention to your case from really experts to help you, and it's a double-edged sword. You don't want, like you say, you don't want some cowboy kind of stuff going on out there, and that may or may not be happening. Most surgeons are careful people, and I don't think they're going to do something that they're not comfortable with. Most of the time it's them having the skill and saying, here's a case, what do you think about me performing it in this fashion or using this kind of mesh? And so I think a lot of the fears, while certainly important, most surgeons are careful people, and they're not going to do something crazy for the most part unless they're comfortable with the technique.
Mm-hmm. So we had talked about the IHC a couple of years ago in a debate panel for On the Spot with Ed Felix and Dana Tellem and Ajita Prabhu. And when we talked about it then, we talked about concerns surrounding it, and really all chat rooms for surgeons about litigation potential, leaving yourself vulnerable. And how would you say these groups have answered those concerns?
I think, I don't know that they've answered it directly. I think that most of the sites have been vetted by lawyers.
Mm-hmm.
The proper things have been done to protect people. Certainly, I'm sure plaintiffs' attorneys could think of ways to get around some of those things, but it hasn't been as big of an issue as when we first started talking about it. And again, I think it gets back to people being safe, and again, the sites, especially the IHC, they've been well vetted by lawyers.
And really now it's a legitimate source of education.
Oh, it's huge. Like I say, it changed everything. You don't have to wait every year. You don't have to go back to a meeting or whatever. You can get instantaneous response from experts. So it's a huge thing.
Mm-hmm.
Yeah.
So next, let's talk about the America Hernia Society Quality Collaborative. Maybe just touch a little bit for us on its current state and the impact on the need for meaningful data.
Yeah, I think it's very important. Ben Polus and Mike Rosen came up with this, and we didn't have, in the United States, we don't have good ways to follow up our hernia patients. Our country's 300 million people. Everyone would always talk about Denmark and the Scandinavian countries. They have nationwide databases, but that's easy to do when your population's only 6 million. It's an easy thing to do. And so we haven't been able to do that kind of thing in the United States. And so short of a nationwide thing, Ben and Mike came up with this idea where practicing surgeons enter their data in a real time when you do the case. You enter it that day, it goes into a database and where it's analyzed and collected, and then you're compared against others that are in the database. And it started out small, it's become a very, very prominent thing. The companies have buy-in, the FDA has buy-in. The FDA understands that they've not done as good a job with mesh. We talked about that earlier. They're looking for help in trying to look at these products and are they safe. This gives them a way of looking at real-time data to see if they're safe. The companies at the same time get to see how are my products doing. So I think it's still a very important thing, and the Quality Collaborative is expanding, trying to look at long-term follow-up, things that we haven't had in the hernia world, which we absolutely have to try to stratify what patients need, what repair, when, what kind of mesh, all those things. We don't know that, and hopefully this will help us understand some of those things.
For groups that are looking at joining but haven't yet, what is what do they need to be doing once it starts? How much time does it take to enter that information? Who's doing it in terms of staff and time and money? What does the average group need to be putting into that?
Well, that's the hard thing. It does take some time. It's not lengthy, but it takes time. If you have a surgeon in private practice that's busy doing 4 or 5 cases a day going, it's very difficult for him or her to sit down and put that data in because they're moving on to the next case. And that's what the QC has run up against. They have a certain number that are dedicated to hernia and want to put that in. The time that it takes, we've got different options in our office where we actually have the forms. Instead of getting onto the website, we have the forms in front of us. We just fill the forms out, and then our administrative assistants put it into the data bank. So there's different things, but it takes some time, and you have to be dedicated to it. And some of the busy practicing general surgeons that don't focus on hernia may not be as interested in doing that.
Well, but once you put that data in, once you have the buy-in and you've allotted staff and time and money toward it, you not only are doing something for the greater good and the larger set of data, like you had mentioned with the FDA and others, it helps the individual practice, right? Because
absolutely.
They're able to track their outcomes much more efficiently.
Absolutely, and all surgeons out there know now that the magic is just what you say. It's outcomes, your metrics, how are you doing?
Yeah.
And you're compared and you're tiered to other surgeons, so you've got to have the data. So this is a way, instead of you having to go out and come up with your own way, this is a way to throw that stuff in there and have those answers when the insurance company comes or the American board comes or whoever is checking up on you. At least you've got some data to show.
Good to have.
Yeah.
Well, thank you for being here today, Kyle.
Oh, my pleasure. Good to talk to you.
Yep.